Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, a randomized phase 2 study of clofarabine-based consolidation for younger adults with acute myeloid leukemia in first remission by Xavier Thomas et al. My name is Ken Bradstock, and I am a clinical professor of medicine at the Sydney Medical School, University of Sydney, in Sydney, Australia. My oncological specialty is hematological oncology. The major challenge faced by hematologists and oncologists in treating younger patients with acute myeloid leukemia, or AML, is to prevent relapse after complete remission is achieved using induction chemotherapy. In recently reported large collaborative group clinical trials, 70 to 80% of patients aged from late teenage up to 60 years achieve a complete remission using a combination of cytarabine and an anthracycline, typically daunorubicin, both in various doses and schedules, but essentially based on the 7-3 regimen described over 30 years ago. However, without the intervention of an elective allogeneic stem cell transplant in first remission, a majority of patients will subsequently relapse and require additional salvage treatment. Progress over the last 3 decades in improving the outcome for AML patients has been incremental and modest. Prolonged low-dose maintenance chemotherapy, such as that used in the treatment of acute lymphoblastic leukemia, has proved to be of marginal benefit in AML and has been generally discarded. Consolidation therapy with the same agents as used in induction, but in attenuated schedules, is usually well tolerated, but provides only a modest reduction in risk of relapse. However, in a landmark study reported by the Cancer and Leukemia Group B in 1994, intensification of consolidation therapy using repeated cycles of high-dose cytarabine, which I will abbreviate to HiDAC, given as 6 doses of 3 grams per metre squared per course, substantially improved leukemia-free survival compared to lower-dose schedules, with 2-year leukemia-free survival of 44%. This improvement came at the cost of increased myelotoxicity and non-hematologic toxicities, resulting in only 56% of patients in this trial randomized to the high-dose cytarabine arm being able to complete all 4 planned consolidation courses. The principle of intensified consolidation therapy using high-dose cytarabine or other drugs to reduce relapse risk in younger patients has now been confirmed by other collaborative groups, but none has shown a significant improvement over the original CALGB results. Direct comparison of these studies is difficult due to a number of confounding factors: the use of different primary endpoints, relapse or leukemia-free survival versus overall survival, the varying length of follow-up of patients, the differing mixes of clinical and biological features of the enrolled patients, in particular the age range, as well as the cytogenetic and gene mutation profile of cases, and the percentage of patients undergoing elective allogeneic stem cell transplant in first remission, which appears to be steadily rising with time, such that up to half of patients in recent trials have been transplanted. Nevertheless, 2 large randomized trials have confirmed the benefit of intensification of consolidation therapy using multiple cycles of high-dose cytarabine or other drugs. CALGB Study 9222 showed equivalent outcomes using 3 courses of multi-drug chemotherapy, including 1 high-dose cytarabine course, compared with 3 courses of high-dose cytarabine. The Japanese Acute Leukemia Study Group similarly compared 3 cycles of high-dose cytarabine in consolidation to 4 intensive cycles of multi-agent chemotherapy, with equivalent outcomes again observed. An alternative way forward would be the introduction of major new agents active against AML. The CD33 immunotoxin Mylotarg has clear efficacy against AML, but toxicity problems and a narrow therapeutic window have made it difficult to incorporate into therapeutic protocols. The class of nucleoside analogues, including fludarabine and clofarabine, are another possible option, and clofarabine is the subject of this podcast. Clofarabine has activity against AML both as a single agent and in combination with cytarabine, but has not shown superiority to standard therapies either in previously untreated elderly AML patients or in the relapse setting. However, Thomas and colleagues reasoned that clofarabine might be a useful drug to intensify consolidation therapy for AML and designed a randomized trial to compare the combination of clofarabine and intermediate dose cytarabine with 3 courses of the original CALGB HiDAC schedule. Clofarabine was used at a dose of 40 milligrams per meter squared per day for 4 days in a pilot study in this context by these investigators, but proved too toxic, and the dose was reduced to 30 milligrams per meter squared per day for 4 days, in combination with cytarabine 1 gram per meter squared daily for 5 days. This combination was termed CLARA or CLARA by the investigators. Therefore, the comparison was between 18 grams per square metre cytarabine per course versus 5 grams per square metre cytarabine plus clofarabine. In the article that accompanies this podcast, Thomas and colleagues from 33 French centres describe the outcome of the Alpha 0702 trial, comparing these 2 consolidation strategies. Several comments need to be made about the trial design and patient eligibility criteria. First, AML patients eligible for randomization into one of the 2 consolidation arms were in first remission after receiving 1 or 2 cycles of induction chemotherapy, which was given at a higher intensity than the standard 7 and 3 regimen, namely daunorubicin at 60 milligrams per meter squared per day on 3 days and a cumulative cytarabine dose of 7.5 grams per meter square. Second, patients with favourable karyotype and gene mutation profiles were excluded. This involved not only cases with core binding factor translocations, but also those with normal cytogenetics, plus mutations in the CEBP alpha gene, or the NPM1 gene, with wild-type FLT3 gene, based on European Leukemia Net guidelines. The study population therefore consisted of cases with adverse or intermediate prognoses. Thirdly, patients who had an identified allogeneic donor by the time of randomization were also excluded. Fourth, patients who had a donor identified after randomization could subsequently undergo transplant in first remission, either by withdrawal during the consolidation trial or after completion of planned treatment. In fact, half of the randomized patients had an allogeneic transplant during first remission. This high rate required a change in the statistical design during the trial to incorporate the potential confounding effect of transplant as a time-dependent factor. The Alpha 0702 trial recruited 713 patients over 4.5 years, with 616, or 84.6%, achieving remission. After exclusion of favourable risk cases and those with donors, 221 were randomised, 107 to CLARA and 114 to HiDAC. The median age was 48 years, the oldest patient was 55 years, and 60% of cases were intermediate risk by ELN criteria. CLARA courses proved to be more toxic than HiDAC, both in terms of myelosuppression and non-hematologic toxicities, particularly liver and gastrointestinal tract. The durations of neutropenia and thrombocytopenia were longer after CLARA than HiDAC, resulting in more episodes of febrile neutropenia and documented infection and delayed start of subsequent courses. Together with a high withdrawal rate for transplant, this resulted in 37% of patients randomized to CLARA receiving all planned 3 courses versus 44% for HiDAC patients. The increased toxicity of CLARA was counterbalanced by improved relapse-free survival, the primary study endpoint. The difference in 2-year relapse-free survival between the 2 arms, 58.5% for CLARA versus 46.5% for HiDAC, based on the original intent-to-treat study design, favoured the CLARA arm but did not reach significance. However, the analysis adjusted for transplant showed a significant improvement in relapse-free survival with a hazard ratio of 0.65 favouring the Clara arm. There were insufficient numbers in subgroups based on age and cytogenetic and genetic risk groups to draw meaningful conclusions, but the benefit of Clara did not appear to favour any particular subgroup over another. The improvement in relapse-free survival was associated with a cumulative risk of relapse of 33.9% in the Clara arm versus 46.5% in the HiDAC arm. There was no difference, however, in overall survival between the two arms, presumably reflecting the subsequent impact of salvage chemotherapy and transplant after relapse. This study by Thomas and colleagues is significant in showing for the first time an improvement in relapse-free survival over the current accepted standard treatment of repeated cycles of high-dose cytarabine. While the clofarabine intermediate-dose cytarabine combination was more toxic than HiDAC, itself a regimen with substantial toxicity, the outcomes reported in this study support the concept that more is better in consolidation treatment. These findings should be confirmed by another collaborative group before being regarded as definitive, but the results of this trial appear to offer a new option for younger patients who do not have a transplant option. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.